My name is Dr. David Hicks. I am the Deputy Health Officer of the Jefferson County Department of Health, and that's here in Birmingham, Alabama. And I have the utmost privilege to speak to you, and the Alabama State Missionary Baptist Convention has been very gracious to allow me to present an update about COVID-19. And I want to add some context to this conversation as it relates to how COVID-19 is impacting vulnerable communities. But first, we have to lay the foundation and framework about really what is COVID-19 all really about, and then what can we do to make a difference in our communities. But we have to understand the historical context to it and really dispel some myths that are out there. So, in this brief time I have with you, that's what I would like to cover. So COVID-19, this is this new virus that has ravaged society. This is a global pandemic. COVID-19 is more contagious than the flu. How do we know that? So one of the things that we look at in public health is called the reproductive number. And that helps us understand how an infectious disease transmits through a community, particularly during an outbreak. So the reproductive number for COVID-19 is between 2 and 3. What does that mean? That means if I have COVID-19, it's likely that I can spread that to 2 to 3 other people. That is more contagious than the influenza virus. So if someone has influenza, the reproductive number is about 1.3. So about 1 in every 3rd person I could potentially infect with influenza. Now, measles is a lot more contagious than both of those. So if someone was infected with measles, we're talking about a number of 15 to 18. So right now we're used to dealing with influenza in society, but COVID-19 is more contagious, and that's why we have to figure out what are the strategies that we have to do to get that reproductive number down, okay? So we want that number to be 1 or less. That means it's not passing to more than 1 person, hopefully less. If we accomplish that goal, then the infection just burns out in society. The outbreak then dissipates and goes away. So that's the overall goal in public health. So recently, we've been hearing reports about a concept called herd immunity. What is that? So herd immunity is essentially if enough people, the herd, the community, gets exposed to COVID-19 and their bodies build up an immune system response, that will provide a sense of community protection. The idea is that if you get infected, your body mounts an immune system response, your body builds up antibodies. Antibodies think of it as the soldiers that are now primed to ward off an attack because they know what the enemy looks like. What we don't know is how long an immune system response really lasts. There's new studies that have come out to say that for someone who has been infected with COVID-19, their body builds up antibodies, but those antibodies start coming out of your system 3 to 4 months down the road. We don't know how strong that immune system response is, so how much level of protection are you really, really getting? So, for herd immunity, the concept is if enough people get exposed, will enough people have immune system protection? There's 2 ways to get herd immunity in society. One would be if everybody got infected, you have maybe 70% of the society infected, enough people in the herd have immune system protection, natural protection, and then that means the disease cannot spread through the community. This is the danger in that with COVID-19. If we allow the community just to get ill and become infected, there's not going to be enough protection, it looks like, for months and months and months. There's no way we can just let this disease just naturally go and people get this natural immune system response to get that infection. So that will not work. Other diseases, it has worked. It won't work with COVID-19. And if you did that, there's going to be more suffering, more death unnecessarily. The best way to get herd immunity is with vaccination, a mass vaccination. But a vaccine has to work. It has to offer long-term immune system protection. okay? Beyond what potentially the natural disease state does. So right now, if your immune system can give some protection for 3 to 4 months, we would like a vaccine that would give a lot more protection. So when they develop these vaccines, they have to be high quality and they have to last long. There's a lot of vaccines being put out there in development. One of the things, and we'll talk about this later, is that we also have to make sure that those vaccines are being tested in the communities that are the most vulnerable, so we know that it works for the highest risk persons. We have to be included in that conversation and in these trials to make sure things are done safely and that they will work on everybody, not just a select few. So that's what we're hoping for, to get out of this. So we're just trying to buy time in society until we get to a point where there is a really good vaccine out there, when there is really effective treatment. There is no cure for COVID-19 right now. There's therapies that we'll talk about a little later, but still, we have a long way to go. So that's why we need the society as a whole to rally around the public health efforts, what the scientists are saying, what the medical experts are saying. We cannot have politics inserted into this conversation. This is about saving human lives, increasing the quality of life, and making sure we don't have unnecessary suffering in society. So, with that being said, the high-risk groups, those vulnerable people, are the ones that disproportionately are affected in communities of color. Okay? We do know that if you're older, so you're older than age 60, we know if you have comorbid medical conditions. So if you're a diabetic, if you have heart disease, if you have respiratory illness, those put you at high risk. If you have a health condition where your immune system is compromised, for example, cancer, or an autoimmune condition, that puts you at high risk. You're very vulnerable. We know that in these high-risk categories, people of color are disproportionately in those categories for multiple reasons we're going to be talking about. So I think a key thing to think about, and I'm going to read this to you, everyone, Proverbs 31, verse 8 to 9. And this is from the NIV translation. So, speak up for those who cannot speak for themselves. For the rights of all who are destitute, speak up and judge fairly. Defend the rights of the poor and needy. That is what the church just charged to lead society to do. Speak up for those vulnerable people. Make sure they're informed. Make sure they're included in the process. Now, generally in society, irrespective of COVID-19, groups that are considered vulnerable, in addition to some of the ones I named earlier, are people that have chronically ill or they're disabled. We know our veterans suffer disproportionately in society for illnesses. Our immigrant society, minorities, either the very young or those that are older. People that are low income or persons experiencing homelessness. So, generally speaking, irrespective of what the disease or illness is, those groups are already at a disadvantage. I'm going to focus on the minority population because a lot of your parishioners fall within this category. And there's some alarming statistics that are coming out nationally related to COVID-19. Unfortunately, African Americans are 3 times more likely to contract COVID-19 than their white counterparts. In addition, African Americans are roughly 2 times more likely to die from a result of being infected with COVID-19. Okay? So if you look at all of the United States, 22% of all the deaths attributed to COVID-19 are in the black community. But the black community makes up just 13% of the population. That is disparity. That's disproportionate burden of disease in communities of color. Now, we have to ask, why is that? I will tell you that for Black workers, they're more likely to be exposed to COVID-19 than white counterparts. 43% of people of color, that's Black, in addition to Latinos, the workers that are employed in services in these production jobs, they cannot do remote work. They can't work from home because of the type of work that they tend to have. So that's 43% of workers, Black workers, are employed in these fields where they cannot work remotely from home. Now, in comparison, for white workers, about 1 in 4 are holding those types of jobs compared to the Blacks. So this is people that work in public transit, our healthcare workers, people that are on the front lines, okay? Now you look at frontline workers, 17% of all frontline workers in society are African American. So when we say we can work from home or practice social distancing, it means different things in different communities depending on if you can do that at all. We have to be sensitive to those things and understand. We have to challenge our leadership to recognize these things because we're going to continue to see these disparities perpetuating. We're talking about COVID-19 today, but this is a systemic problem in society. COVID-19 has highlighted these issues, but COVID-19 isn't causing these issues and these disparities. We know that African Americans have to rely on public transportation more than other groups. We know that, relatively speaking, African Americans may have to live in more cramped apartments, or there may be multi-generational homes where you can't practice social distancing as much as possible. We also know that this disproportionate amount of African Americans are incarcerated. That's difficulty social distancing in our correctional facilities. We talked about these essential workers, those frontline workers, our public safety personnel, where those are another group. So we know that people that have underlying conditions, we talked about the heart disease, the respiratory illnesses, disproportionately that's impacted the African American community more than any other group. So when we look at what causes poor health outcomes in society, there's been a lot of studies about this. What I'll tell you is that the behaviors, the choices that we make, how we eat, our physical activity, things like that, accounts for about 50% of what health outcomes in society is going to be, right? Our environment around us, where we live, what's in our community, makes up about 20% of what's going to happen to us in our health outcomes. So we can attribute it 20% to the environmental factors, okay? Genetics, generally speaking, makes up about 20% of explanation of why we will get the health outcomes we have. Now, for COVID-19, we cannot blame the disparities on genetic predisposition. There have been studies done about the role in genetics in COVID-19. Now, the one thing we do know is that for persons with the A blood type, they have about a 1.5 higher risk of getting COVID-19. And persons with the O blood type have a lower risk. Scientists are still trying to figure out why. There have been studies in Italy and Spain that have seen some genetic variations in people's DNA that puts them at higher risk of getting respiratory illness from COVID-19. However, I have not seen any studies, particularly that say that there's some genetic reason why people of color are getting disproportionate share of the disease burden. So we cannot blame this on genetics, okay? Another category is access to care. So that makes up 10% of the outcomes that we end up having in society are due to access issues, right? So think about this. 80% of the things that drive how health outcomes occur in society has nothing to do with genetics, and I would say it's probably a lot less for COVID-19. This is those health behaviors and the choices that are made, the environment that we live in, access to healthcare and healthcare systems. That's what's driving it. Fundamentally, what is attributing to even those factors, especially in communities of color. Now, in the medical community and public health community, one of the buzzwords that we've been talking about for the past several years is something called the social determinants of health. What are those societal factors, those structural factors that drive how health outcomes play out in society? So I'm going to list some of those things. Economic stability is a factor. So we know, going back to what I mentioned earlier, poverty, financial and community resources. If you do not have the financial resources, your health outcomes will be poor. I think we all know that. Then another category is called the social and community context. So what that is socially, how do we adapt to what's going on around us and within our networks? There is a concept called John Henryism, the John Henry syndrome. This is pretty fascinating. There was this gentleman named John Henry, and this is not from the legend of John Henry, but another real-life John Henry who, what they found out is that really hardworking person. But this person started getting burdened with heart disease and heart troubles. And what they found, and this is really alarming, is that in communities of color and African Americans, we're very resilient people. And when you're really resilient and you're fighting hard against the system to move up, what happens is they're seeing a correlation with that hard fight and that striving, getting through the system and all the challenges in society, and that is triggering something inside our bodies and the hormones and different things in our body that is actually contributing to high blood pressure and heart disease. So if you have to fight harder and struggle more in society to achieve and get somewhere, there's actually negative effects in your body for that. So then we wonder, how come certain communities are burdened more? There are physiological changes in our body that are caused by things that's around us in society that we have to deal with on a daily basis. That's what we have to dissect. That's what we have to understand in communities of color. We're talking about COVID-19, but you can apply this to multiple medical conditions. So the next issue is the neighborhood, the community we live in, the built environment around us. That helps determine what's happening in health. So we know historically that communities of color were redlined. And this is structural racism, where people could not live in certain neighborhoods and communities, and the banking system set up rules to let certain people go in parts of the community and other people couldn't. So here in Birmingham, we see that play out, where you see where a lot of the disease burden is where people of color were forced to live next to polluting businesses and industries. And you see that the historical remnants of this institutional racism, structural racism, puts people of color at a competitive disadvantage because of things beyond their means, outside of their control. And then we have generational curses in people's lives and health. And it's not a genetic issue. This is a societal issue. This is a community issue. This is institutional racism. This is discrimination and practices and policies that have happened in communities of color. We also know, often in communities of color, there may be food deserts. That means in your community, you may not have access to a grocery store that has high quality produce and other things. That's a structural issue. That's structurally in our communities. Do we have the resources we need to successfully take care of ourselves? Next thing, let's talk about the healthcare system and access to healthcare systems. So one thing that's really important is this concept of medical mistrust. There have been so many historical wrongs enacted on people of color, particularly in African American community. Everyone knows about the Tuskegee syphilis study in Alabama. But that's one of many sins of the medical profession. There's been medical experimentation on vulnerable groups without them knowing what was going on. And this was all done in the name of science, in the name of medical advances. But there was extreme, tragic stories that we tell over and over and over again, where people of color were taken advantage of. Over time, that has led to distrust of the whole system. We have to face that reality. We have to own up to it. So, other thing that we're also seeing, particularly with COVID-19, is myths and misperceptions that are persisting through communities. So early on with COVID-19, there was something circulating on social media saying that people of color were immune to getting COVID-19. Black people could not get sick. This was popular, it was spreading around. Another myth was that the melanin in people's skin offers protective qualities, and that means people of color won't get sick as well. I'll give you another one. We've seen messaging of saying, and this goes back to the medical mistrust, is don't allow them to put a swab in your nose or to draw blood from you, because if you allow that to happen, they are injecting you with COVID-19 purposefully, and you will get sick and you will die. That's a lie, but that's out there. I talked earlier about we have to figure out how to do vaccine development and include people of color in the trials and everything. Well, if you have medical mistrust, are you going to enroll in some of these studies to see if the vaccine could be effective in communities of color? When the vaccines get developed and there's going to be mass vaccination campaigns, you'll see that heavily pushed out there. The people that don't trust the system or trust the government may shy away from allowing themselves to get vaccinated. So we have to have these conversations now, but we can't just say, you need to get a vaccine, you have to get this. We have to address the historical wrongs and the sins in the past. We have to own up to it. We have to ask for forgiveness. We have to ask the community, how can we better engage you? How can you tell us what we need to do to be better? To regain trust. And that's not going to be an overnight thing. But we have to face this head on. We have to do this now. Or else people of color will still be left out of the treatments that work. We know historically that when medicines get developed and these massive research studies, and you're having thousands and thousands of people enrolled, people of color may not be included in those research studies and those trials. So the medication comes out on the market, we put it out there, and then we wonder, how come this one is not as effective in this group versus that group? Did we consider including people of color on the front end, but doing it in a very sensitive and respectful way? Are we properly informing people of what's going on? So this is not a simple thing of just saying, you need to do this, you need to do that. We need a lot more education. We need to address all these factors we talked about. Next thing I want to comment on is discrimination. So, and there's subconscious and conscious bias in the way a lot of things happen in healthcare space. We know that if you control for what someone's medical condition is, their age, that we even know subconsciously that the medical community still offers different treatments subconsciously to this person versus that one, or make assumptions about one group versus the other. So subconsciously or consciously, that leads to decisions that get made in policies and how we interact with people. So we have to have self-awareness individually and then as society as a whole, and don't bury our heads in the sand about all these factors that are contributing to why we're having these disparities and why people of color are burdened by COVID-19 and other medical conditions. And it's not because you are black. It's because you are perhaps black in a world and society that has treated you wrong and set you up for failure. Now, I used a term earlier and I talked about institutional racism. And in Alabama, and when you go back when the Constitution of Alabama was written and the laws that were passed in this Jim Crow era, there were laws on the books that said that a white nurse could not treat a black patient. And if that nurse did so, that nurse was fined. That is institutional racism. That is, we use laws and policies to give different treatment to one group or worse treatment to one group. Remnants of that still perpetuate. We have changed laws, but there's still practices that are happening nowadays, even if it's not on the books, that we have to address. So racism is still here, and we have to figure out what we're going to do about it and not just talk about it. And that's why I think, we're having this COVID-19 pandemic colliding with society having to deal with the racism in the past and in the present. And right now we're in this very vulnerable point in society and in the United States because everybody is on edge, everyone's under stress. But the only way we can get through all of this, the pandemic of racism and the pandemic of COVID-19, is to face the music, address it, but do things different than we ever done in the past. Because all the things we've done in the past, they have not fixed the problem. This is root level things. This is systemic problems that we have. We can't keep looking at the surface level anymore. We have to get to the root of those social determinants of health and figure out how we're going to do from a policy perspective, how we're going to rally our communities around these things, hold everyone accountable, be self-aware, and pool our resources together to address all these issues. The next social determinant of health, the final thing I want to just comment on, is education, okay? So if you aren't as educated, that tends to lead to poor health outcomes. So our education systems, we know right now that we're grappling with what do we do with schools and children going back. And we know there are some school districts that say, and I tend to agree, that now may not be the time to go back to school right now. But we talk about virtual learning. Well, can somebody virtually learn if they don't have internet access or a device? So when we think about making mandates and policies, we have to have an equity lens, a lens to say, are we including everybody in the conversation? And are we understanding what's the unintended consequences of the choices that we make and the policies and things we push out there? And then once we get an understanding of those things, then what we need to do is put resources in. There are some groups that need more resources than another group. That's the difference between equality and equity. Equality means that everybody gets the same thing. We need to get to a point where we're not asking for equality, we're asking for equity. Equity means that because of that competitive disadvantage that I talked about earlier, there's some groups that need a lot more resources because historically they've been put behind the 8 ball so far that you can't just give them the same equal thing. They need more. That's what we have to do. Identify those most vulnerable groups and get an even playing field. And that means you need more resources in certain parts of society than others. That's the right thing to do. So I'm going to kind of pull back to COVID-19, and then I'll try to put this all together. So for COVID-19, I just want to highlight some of these proven strategies. Now, when I first started talking, I talked about that reproductive number, trying to get that, how likely this disease is able to spread from one person to the other. We need to get that number down because we don't want COVID-19 spreading like wildfire. These are the things that are proven to work. Social distancing, we've talked about that. Now, we know the challenges of social distancing, particularly in people of color, because the issues we talked about earlier about frontline workers and if you can do that. But we know that social distancing, quote unquote, flattens the curve. What does that mean? That means if we don't social distance and we go about society as we were doing a year ago, the amount of spread keeps on, it multiplies. I infect 2 to 3 other people, those people infect 2 other people, the epidemic goes up. That's the curve going up. We need to flatten that down to buy us time. So social distancing means I'm keeping myself at least 6 feet away. So, because I don't want, unbeknownst to me, COVID-19 to spread. Because we know we have a significant amount of people that asymptomatically are spreading COVID-19. That means they don't have symptoms, they never have symptoms, but they have it and they're contagious. And it's spreading out there. We're seeing a trend where COVID-19 is being spread amongst the younger population. So our 20-year-olds and our 30-year-olds are the ones who's spreading it, but they're not the ones who's suffering from it as much. They're not dying from it as much. So it's spreading in that population, but then they bring it back to their family members and their loved ones and their neighbors. And then we see the increased hospital rates. We see increased deaths, and it's impacting the communities of color disproportionately. So we have to think about our decisions and how that impacts other people around us. And we have to be careful because we could be the link in that chain where we were a little reckless, we didn't follow the recommendations, we spread it to one person, he spread it to another person, and someone died because of it. So the next thing is isolation and quarantine, okay? So when we find somebody who's positive for COVID-19 or they were exposed to it, a high-risk exposure means you were within 6 feet of that person for about at least 15 minutes at a time. That means as I'm talking and communicating with you, the virus spreads out. It's in the air. You breathe it in. You may touch your face, your nose. You need to be isolated. If you're a high-risk contact to someone who is positive, isolate. You go home. You don't go to work. Call your healthcare provider. They may want you to get a test. And then when they give you the clearance, then you can go back to work, hopefully, or you can re-engage. But that's your part. And when we find that someone is positive, that person's under home quarantine, and their household contacts are on mandatory home quarantine. The difference between isolation and quarantine is legal. The health department will legally issue orders and say you're under quarantine, and then legally we can do something about it if you violate that. But you still need to isolate yourself if you believe you have it until you know for sure you don't, or your healthcare provider told you no, or you're released off of quarantine. That is removing yourself out of the pool of people that can potentially affect others. Hand cleaning, hand hygiene, washing our hands. Good old-fashioned soap and water work phenomenally well, right? We don't need to go out and buy all this fancy stuff if we have soap and water. But if you do use those alcohol-based hand gels, that's great. However you keep yourself clean, either washing hands with soap and water or using the alcohol-based hand gels, we need to do that because we're constantly touching surfaces. Imagine if you're in church and you have to move a chair. The next person comes behind you to pick up that chair and move it. They touch that surface, you touch the surface. That's how things spread. In churches, we get worried because in the ventilation systems, there have been studies that have shown that COVID-19, depending on how the ductwork in your church, can spread through. We get concerned of a choir that's singing and projecting out, pushing that air outwards. And how could that affect your parishioners? So when we have these congregate settings in churches, we have to be really, really, really careful. So we know that it's very, very important for congregations to share together. We know that doing virtual, church, it's a temporary solution, but we know that we have to gather together as a people, but we have to do it safely, and now is not the time to do that. We need to buy more time. Next, face coverings. This has been a political hot potato, but this is not a political issue. There's been studies that have shown that for people that wear that cloth face covering, it can decrease the spread transmission rate by 50% from one person to the next. The face covering really protects you from me. What if I'm an asymptomatic person? I don't know I have it. That's my duty to take care of my fellow members in society, okay? Those droplets that could come out, hopefully some of the fabric catches it. It's not gonna catch 100%. But if you do that, plus your distancing, that gives society a fighting chance. So that's why we pushed out that. Early on, we weren't telling people to do that, so things have changed. And we know people have been frustrated. People will say, well, you say one thing, and then you change the recommendations next. As we learn more, we do better. Science is driving the recommendations that the health department comes out with. Testing. I want to comment on getting a test. So when the state was locked down, everyone was terrified. We were seeing what was happening in other countries. We did a phenomenal job. We start seeing that the percent of people that were testing positive was about 4%. And the World Health Organization tells us that we want our positivity rate to be below 5%. So we were trying to keep it contained. And then things start opening up. The holidays start happening. We got too laxed. Our positivity rate jumped. We're now up to about 15% of positivity rate here locally. And there's different pockets in society where they have a positivity rate of 20-something%. When the positivity rate goes that high, that means there's so much disease floating around. It's not because there's more testing being done, because this is a percent. Of all the people being tested, this is the percent that are coming out positive. So when you have a higher positivity rate, that means we have to do more testing to identify all the diseases floating out there. So then we can get people in quarantine and isolation, so then we can get that back down. We're going way in the wrong direction. So we have to use science and the numbers to drive our decision making. Next thing, treatment. Well, right now, most people, hopefully, will have just a mild case. Over-the-counter medications, talking to your primary care provider, they'll give you things, they may prescribe something. There's certain medicines that are out there, but those are reserved for people that are hospitalized or really, really sick. So we've heard about there's a medication called remdesivir. It's an antiviral medication because COVID-19 is a viral infection. That's been used for people that are hospitalized. It's not a magic pill, but what it does is it decreases how long you have COVID-19. Hydroxychloroquine. This is something we've heard on the news about. There's been some studies saying this drug may work, it may not work. Right now, that should be reserved for people in the hospital. They're doing some studies to see if they combine it with an antibiotic, and some of these antibiotics have some anti-inflammatory properties to them. It's just not any antibiotic. There may be some benefit, but it's still not a magic pill. So there is no cure for COVID-19. So, with all that being said, what do we need to do for communities of color? Because there's social factors that's driving this. We need to have more targeted strategies for those most vulnerable groups in society. So, let me give you a couple examples. So, we need to do targeted testing. So, if you know there are communities that are more burdened, that's the sweet spot. We need to have targeted testing efforts for the most vulnerable communities. So we see that happening in certain parts of the state, and we need to do more of that. We need to do mobile testing to bring it to people, because we know transportation is an issue. I'm very, very pleased because the churches, you have all stepped up and said, I will offer my church parking lot for testing. So we need to make more of these connections and strengthen the network and have our partners that can do testing to be able to engage with our faith leaders and offer the testing in those communities. We need you as the faith leaders to then push out that messaging because you're trusted in the community. And you are the voice and to rally the troops to get them to come in and get that testing if they need to get it done. Next is targeted messaging. The way we consume information nowadays is not the way we've done it in the past. So you will see us get on the news and we'll do press conferences, but there's some people that don't get their news and information that way. We're living in the age right now with social media, so we have to leverage these platforms, particularly for the younger generation that consumes their information and news in a different way. So social media and websites is one thing. We still do traditional billboards, and we still do other things. But another thing that's, I think, traditional that we need to also be able to do with community engagement is, at least in my perspective, is have like a street outreach team, doing it safely, old-fashioned knocking on doors, putting out that information. We have to become creative with the ways that we are engaging in communities that may have medical distrust issues, historical racism and discrimination, communities that may have myths floating around. So we have to engage head on. We need to model the behaviors that we want people to do. So vulnerable groups need to see people that look like them, talk like them, modeling the behavior choices. We have to be wearing those face coverings. We have to show people that we're willing to get tested ourselves. If we tell someone to get tested, are we willing to do it ourselves? There's been some campaigns where we've looked at trying to get some of our leaders to show a video of them getting swabbed, to dispel the myths that are out there. We need to acknowledge those historical wrongs that are leading to those mistrusts. Acknowledge how we've failed in the past. Acknowledge how we've not included vulnerable groups and people of color the right way. In order for us to do this, we have to own up to it, lay it out on the table. We need to engage our community stakeholders. Our clergy, you are a key stakeholder group. Our political leaders are key. Our community activists, neighborhood presidents, all those are the ones on the ground that the community trusts and hears from. So we have to bridge this divide from the academic, governmental aspects of society, and how do we translate that into the ground? But you are the gatekeeper. We have to engage with the gatekeeper. We have to gain your trust, and as we do that, you tell us how we need to allow us to come into the community on the community's terms. Let the community stakeholders speak and vouch if you know that this is a trusted partner. We know that there's been reputations for institutions to come into a community, jump in, dictate this is what you need, and pull out. That's not the way it needs to go. This community knows what they need. The community knows how we need to engage. You need to work with the community to challenge the system on a better way to go about how we engage. We then, on a macro level, need to challenge the status quo. We need to address those social determinants of health. We need to address discrimination and racism. And this is a policy thing. This is organizations have to change their policies and practices and demonstrate that. And it's not just a feel-good moment, not a photo op. This is sustained change. And when you make the change, you have to include the right people in the conversation to inform that change. Final thing, and just to make everybody aware, the Alabama Conference of Black Mayors has a noun-included task force, and I've had the honor to serve on this task force. And all these things that I just mentioned is what this task force is looking at. I'm going to read to you the charge of this task force. It's to ensure awareness and adoption of public health practices that lead to improved COVID-19 research, testing, vaccination amongst Alabama's most vulnerable communities. So I appreciate the Alabama Conference of Black Mayors who's taking a lead to have these tough conversations and understand the issues. They're not the only group, but the work that they're doing and many others needs to be coalesced. We need to work as a unit. There's strength in numbers. We all have the power to change the trajectory and the path that vulnerable groups and communities of color have been going far too long on. And so we need to do this all together. We need to challenge the system. We have to be informed and educated. We have to be healthy. We have to take care of the temple that we are blessed with. And with that being said, I'm concluding my remarks. Thank you so much for allowing me to present to you. Have a wonderful, wonderful, and healthy year.